Hello, my name is Tahmina Mustafa and I am Professor of International Health at University of Bergen. In this lecture, I am going to talk about natural course of tuberculosis infection, some aspects of immunology and pathology. In this, in this lecture, you will learn about introduction to the various disease manifestations, primary TB, latent TB, secondary or reactivated TB, also how disease develops, namely pathogenesis, and also how disease is spread from person to person, and what is the role of host immune response in the development and spread of disease. Tuberculosis is an infection caused by a bacteria called Mycobacterium tuberculosis. In humans, the common species of mycobacteria that causes disease are Mycobacterium tuberculosis, Mycobacterium bovis, africanum, microti, and canete. There are several species of mycobacteria that do not cause tuberculosis disease. These mycobacteria are present in the environment. However, in immune compromised individuals, some of these mycobacteria do lead to disease manifestation. The enigma of Mycobacterium tuberculosis is that it is an obligate human parasite, even though humans are most resistant than any of the animals used for study. Mycobacterium tuberculosis is an obligate human parasite because it can almost only be transmitted to new hosts by people. Humans are more resistant to tuberculosis because most develop effective immunity against primary tuberculosis in weeks, whereas most animals die within months of progressive disease. This benefits the organism because it maintains the health of the host, who can then spread infection frequently for decades. Mycobacterium tuberculosis is an ancient human pathogen that can persist indefinitely in very small populations of as little as 200 people. The life cycle of Mycobacterium tuberculosis is to infect a person, frequently a child, and then hide for like 10 to 30 years before reactivating to produce a cavity in the lung from which organisms are coughed up over a period of decades to infect new individuals. Tuberculosis is spread person to person through the air via droplet nuclei. Mycobacterium tuberculosis may be expelled when an infectious person coughs, sneezes, speaks, or sings. Transmission occurs when another person inhales droplet nuclei. The droplets that are small enough in size, like 2 micrometer or less, reach the lower respiratory tract. Droplets of a larger size are efficiently excluded from the lower respiratory tract by the physical barriers of the nasopharynx and upper respiratory tract. Of the inhaled bacilli, only 6% reach the alveoli. The respiratory bronchial epithelium can produce antimicrobial peptides with a wide spectrum of activity, which probably explains the resistance of the respiratory bronchial epithelium to infection by Mycobacterium tuberculosis. The innate immune response may suffice to control infection before the development of acquired immune response, as a small number of individuals, such as close family contacts or health workers, do not develop a positive skin test or tuberculosis disease despite intense and prolonged exposure. If the host is unable to kill the bacilli, the organisms can begin to multiply and grow shortly after infection. This multiplication happens within the alveoli where the infection begins. A small number of tubercle bacilli, they enter bloodstream and spread throughout the body. 2 to 6 weeks after the primary infection, the body's immune system develops cell-mediated immunity to mycobacterial antigens. The expression of acquired specific resistance to Mycobacterium tuberculosis is associated with cessation of progressive growth of the bacilli, formation of a granulomatous structure at the site of infection, a primary complex in the lung and in the corresponding lymph node or nodes, and this is known as Ghon's complex. There is concomitant emergence of the capacity of the host to mount delayed type hypersensitivity response to mycobacterial antigens inoculated at a separate site. T cells specifically respond to mycobacterial antigens are present in blood and regions. Th1 type of cytokine pattern is usually seen. This gross picture of lung shows a primary complex where a lesion can be seen uh, in the periphery of the lung parenchyma and a corresponding lesion in a lymph node. In approximately 90% of the infected individuals, both the primary pulmonary lesions and the lesions in the draining lymph nodes, they heal spontaneously and clinical disease never appears. All the bacilli, however, might not be eliminated by the immune response and some may persist in the body. The chance that a person will be infected after exposure to an infectious source depends on many factors like intensity, frequency, and duration of the exposure to the infectious person. It will also depend on the various characteristics of the individual, such as age, genetic factors, immunological and nutritional status of the host, intercurrent diseases, etc. One sputum positive person will infect on an average 10 persons during 1 year. A detected smear positive case very soon will become non-infectious after commencement of adequate chemotherapy. In countries with poor case finding and treatment facilities, a source case may on an average infect more than 20 persons. Following primary infection, approximately 10% of the infected individuals progress to disease. Clinical disease can occur weeks to years after the primary infection. It is estimated that about 54% of the primary TB occurs within 1 year and 80% within 2 years of infection. With high risk of tuberculosis infection, primary TB occurs mostly in young children, but also among young persons and adults in communities with low risk of infection. The risk of development of disease depends on characteristics like age, sex, intensity and duration of exposure, and virulence of the infecting Mycobacterium strain. Genetic factors, nutritional, immunological, and psychological status, for example, ability of the person to cope with stress, also intercurrent illnesses like human immune deficiency virus infection, diabetes mellitus, use of immunosuppressive drugs, etc. Primary disease can result as a direct progression of the primary complex or from the sites where bacilli are implanted by hematogenous spread from the primary lesion, for example, in the kidneys, ends of long bones, spine, meninges in brain, and apicoposterior areas of the lungs. Lung is the most common involved organ, especially in adolescents, where pulmonary TB constitutes about 90% of the cases, and cavitary pulmonary TB occurs in 21% of all primary cases. In young children, extrapulmonary TB, usually TB adenitis and meningeal TB, is more common, although this observation could be biased because of difficulty of diagnosing pulmonary TB in children. The infectiousness of a person suffering from primary TB will differ depending on the age. In children between 0 to 14 years, more than 95% of the cases are smear negative. In persons between 15 to 30 years, 24% of the cases are smear positive. This figure summarizes the possible natural course of infection in humans following infection with Mycobacterium tuberculosis. There is no scale along the axes. After primary disease, the disease can heal itself in about 50% of cases, or it can be cured after chemotherapy. In either case, live bacilli can remain in the host and the person returns to a non-symptomatic stage and remains tuberculin test positive or IGRA positive. Latent infection is a phase when the person harbors Mycobacterium tuberculosis in body but has no signs or symptoms of the disease. This can occur after primary infection or after primary disease, even when it is cured by itself or by chemotherapy. Here, the host immune response has been generated to control the pathogen and force it into a quiescent state. Dormant bacilli can remain alive within the human host for lifetime. Individuals with latent TB do not transmit the disease. The diagnosis of latent TB is determined by the absence of clinical disease and either a positive tuberculin skin test or the new IGRA test, which we will come back to in other lectures, or a chest radiograph that demonstrates scars indicative of old TB. Post-primary TB occurs mostly in adults and elderly and may develop from an endogenous reactivation of latent infection or from exogenous reinfection. As it is not possible to detect a reinfection by tuberculin testing or new IGRA tests in those who have previously been infected, and it cannot be determined directly whether or not exogenous reinfection or endogenous reactivation is important in the development of TB in adults. Studies done on autopsies of people dying of causes other than TB have shown that the primary complexes are calcified and sterilized in about 85% of the cases. This has been taken as evidence for the exogenous reinfection constituting the main cause of adult TB. However, it has been shown that even though the primary lesions are sterilized in majority of the cases, the normal-looking parenchyma at the apical and subapical parts of the lungs harbor live bacilli, the most common site for post-primary TB. These bacilli might have lodged there after primary infection as a result of hematogenous spread, leading to post-primary TB. Furthermore, extrapulmonary TB with no lung disease occurs mostly in the settings of pre-existing latent TB. These findings, they indicate that reactivation of healed pulmonary primary lesions occur rarely and that latency is maintained in the metastatic foci. Most cases of reactivation of TB arise from these metastatic foci, mainly in the apical regions of the lungs. Supporting this concept is detection of apical scarring in a significant number of older persons long before the development of active pulmonary TB. In affluent countries, presently, due to low risk of Mycobacterium tuberculosis infection, endogenous reactivation is the main cause of post-primary TB. This is further supported by the finding that in low TB endemic areas, the rates of active TB is 5 times higher in previously tuberculin positive adults than in tuberculin negative individuals. The evidence for existence of latent Mycobacterium tuberculosis infection comes from the studies that are carried out in low endemic countries. Foreign-born patients carry the strains that are different from the strains identified in close proximity. In high endemic countries, exogenous reinfection may play a more important role in the pathogenesis of pulmonary TB in adults. Post-primary TB or reactivated TB or secondary TB in adults is sputum positive in about 50% of cases, and these cases constitute the main source of infection or reinfection in a population. The pathogenesis of post-primary tuberculosis differs from primary TB in several aspects. In progressive primary tuberculosis, the primary lesions are usually within the lung parenchyma, accompanied by a profound involvement of draining lymph nodes. The disease process has a tendency to become generalized by hematogenous spread, affecting various organs as well as regions of the lung distant from the primary lesion. The granulomas are predominantly of well-organized type with central caseous necrosis. However, in post-primary tuberculosis, the regional lymph nodes typically show little involvement. The disease process tends to remain localized, usually to the apical parts of the lungs. The lesions are large, grow expansively, and granulomas are surrounded by fibrosis. Because the post-primary disease occurs in hosts who have already developed immunity as a result of primary infection, now the host is extremely sensitive to the toxic products of the bacillus, and the large antigenic load which results as a result of infection now becomes toxic to the tissues, leading to increased tissue destruction, necrosis, and formation of cavities. These cavities, they provide an excellent growth medium for the bacilli and excretion of bacilli in the sputum. This form of tuberculosis is therefore highly contagious. Another manifestation of tuberculosis is miliary tuberculosis, which occurs in a small proportion of individuals, usually infants and immune-suppressed people. Here, TB disseminates widely, affecting various organs in the body. It seems that organisms, they drain through the lymphatic system towards the venous side of the blood circulation, reaching the right side of the heart, and from here via pulmonary arteries they spread widely in the lungs. Individual lesions are either microscopic or very small, up to 2 millimeter foci of yellow-white consolidation scattered through the lung parenchyma. It is called miliary because the lesions, they resemble millet seeds. Microscopically, the lesions show structure of granuloma with minute areas of caseous necrosis. Usually, there are no cavities or very less cavities, and many organs are involved. This form of TB is associated with high mortality, and BCG vaccination gives very good protection against this form of disseminated TB, up to 80% protection in infants when given at birth.